Yes, Dr. Isra, there will be. Yes, there will be live query on the next quiz. We are with the problems 37 and 34. 37 and 34. Let's take the 37. Beta, this was the question which was left in the last amenorrhea chapter, secondary amenorrhea. These are the adhesions. These are the adhesions. What is the investigation of choice for Asherman syndrome? HSD is not the investigation of choice. The investigation of choice for the Asherman syndrome is hysteroscopy. Okay, because Asherman is being asked again and again. Last exam also it is asked. What is the presentation of Asherman syndrome? With what clinical complaint a patient comes to us with Asherman syndrome? The most common is amenorrhea. And if amenorrhea is not in the option, then it is, yes, then it is hypomenorrhea. No, beta, it is not anovulation. I am talking about the Asherman. Okay, in Asherman ovulation is there, beta. Okay, hypomenorrhea. Okay, so if amenorrhea is not in the option, then you have to choose hypomenorrhea. Okay, and now you tell me what is the picture you have seen in the question, and what is the treatment? What is the treatment? You have to remove the adhesions, adhesiolysis, because they will again get formed, right? If you will remove, they will again get formed. So what you can do is, you can give high dose estrogen. For why you give high dose estrogen? For hyperproliferation. And you will also put catheter, intrauterine pediatrics Foley's catheter, so that the anterior and posterior surface don't come and touch. Okay, so that the anterior and posterior, in the periphery practice, here we don't put catheter, we put copper T. So either you can put copper T or intrauterine. What it is written in the book is intrauterine pediatric Foley's catheter. Okay, so that the anterior and posterior surface don't come and touch. And we have to give, these are the 3 treatments. Is it okay? So these are adhesions. You can see these are adhesions. Anterior and posterior surface have adhered. So what if this treatment does not treat the patient? What is the next treatment? Can anybody tell me? What is the next treatment? If this does not cure the problem, then what is the next treatment? Surrogacy. IVF. Okay, surrogacy IVF. Not only IVF. We people have a habit of saying that if this problem does not get treated, then the treatment is IVF. No. Not only IVF. It is surrogacy IVF. Okay. Is it okay? Let us take 34. What is the treatment of pituitary adenoma or prolactinoma, pituitary adenoma, or prolactinoma. What is the treatment? The treatment is the tumor size of the prolactin. It decreases in size. It decreases in size if there is. It decreases in size if there is. Yes. Prolactin release is decreased. Okay. So in the tumors, in the small size tumors, we don't go for surgery. We first give bromocriptine or cabergoline. Okay, once the prolactin secretion is decreased, the tumor size also decreases, and sometimes we don't need to do the surgery. Okay, so brain surgeries should be the last preference to do. Next is 19, 13, 7. Okay, let's take 7 then first. Question number 6. Question number 6. What is the primary? Which one is better, bromocriptine or okay, let me tell you. Which one is better? Bromocriptine is to be chosen only if the lady is trying to conceive or the lady is pregnant. Because if the lady is trying to conceive or the lady is pregnant, then you will go for bromocriptine. Otherwise you will go with cabergoline. Okay, if these two conditions are not present, then you will go with cabergoline. Is it okay? Dr. Sheffi, is it okay? Okay, now let us take question number 7. Treatment of DUB in 56 years female. So there is lot of confusion in this question. Please listen carefully. DUB is a symptom, beta. DUB is a symptom, beta. You will never do a hysterectomy. You will never give hormones on the basis of the symptom. You have to come to a diagnosis. For the diagnosis, you will always do curettage. Is it okay? Is it okay? Okay, DUB is a symptom, beta. You will never treat a symptom blindly. You will find out what is the cause. Okay, if in the question it was given that it is a case of cystic glandular hyperplasia, then what is your treatment? What is your treatment if it is cystic glandular hyperplasia? If its age is less than 40, now we know the diagnosis. If its age is less than 40, then what we will do? If its age is less than 40 years, then we will give progesterone. Okay, GnRH can be given, but progesterone is drug of choice. If its family is completed and age is more than 40 years, then of course hysterectomy. Why we will do why we will not do curettage? Because they are writing that it is cystic glandular hyperplasia. Curettage has been done. Curettage has been done. Okay. Let's take question number 7. Question number 7 has been taken. Let's take question number 13 and 19. 13. Question number 13. 24 years woman presents with infertility, hirsutism. Now, what are the complaints, beta? The complaints are infertility, hirsutism, and irregular cycle. All the complaints this girl has. And it is a 24 years female. Now, they have not asked for what the lady is seeking treatment. Okay, so first of all, the irregular cycle and hirsutism will be treated by OCPs. Infertility will be treated by clomiphene. Okay, and for insulin resistance, we will give metformin. Tamoxifen can be given. Tamoxifen can be given for ovulation induction because it is a SERM, selective estrogen receptor modulator. But it is given less often. So we have left here. Okay, because it is a very rarely given, so we have left here. Now, let us say if this patient has come with let us say, Dr. Sheffy, I am not getting your point. Beta, the letrozole is the drug of choice. Letrozole is the drug of choice. Let us take question number 17. Dr. Shefik, please can you explain your point? I am not getting it. Question number 17. Actually for infertility, they have always said that it is clomiphene, but nothing clearly it is mentioned. So I hope they will not ask you. Okay. Beta, letrozole is the drug of choice for PCOD infertility. Okay. Is it okay? Is the best ovulation induction drug. So here let us discuss what are the first. It was when I was studying, I used to study 10 years back, I used to study clomiphene as a drug of choice. But the letrozole has replaced the clomiphene. Why is it so? Why is it so? Can you tell me? A question has come on each or every line. The PYQ has come on each and every line. Can you tell me what is the mechanism of action of letrozole? What is the mechanism of action of letrozole? It is aromatase inhibitor. The clomiphene is a SERM. It blocks the hypothalamus estrogen receptor and increases GnRH. It increases GnRH, okay? But because it is a SERM, it is estrogenic at some site and anti-estrogenic at another site. So I am writing here, please mind this thing. Because of this thing, it has been replaced. It is anti-estrogenic at endometrium. So it decreases the endometrium thickness. Because it decreases the endometrium thickness, so it interferes with implantation. It interferes with implantation. Because it interferes with implantation, so the live birth rate is very less. The live birth rate is very less with clomiphene. This is a key point. Ovulation used to occur. Ovulation हो जाता था, लेकिन बच्चे नहीं पैदा होते थे. ठीक है, बच्चे नहीं पैदा होते थे. अब because this was an aromatase inhibitor, it increases the estrogen and it increases the follicle growth. Okay, it increases the follicle growth. Is it okay? Okay. Now you tell me ki its live birth rate is very high. Its live birth rate is very high as compared to the clomiphene. Okay. Now again two things more. Right? Here it was clomiphene. Here it is letrozole. The clomiphene is such a good drug that it increases the FSH and it causes multifollicular development. An infertile patient always want multiple babies. Okay? But whereas the letrozole, it causes monofollicular development. In spite of this drawback, it has been replaced because the letrozole live birth rate is high. This is not teratogenic. This is teratogenic, but it is given because its half-life is 48 hours. That was the last INSET question. Because you should know that we give this drug letrozole and clomiphene, both we give day 1 to day 5, and fetus is formed at day 14. Zygote is formed at day 14. So by that time it is removed. Okay, letrozole removed from the body. In spite of having all these disadvantages, letrozole is a drug of choice because it is a live birth rate is very high, and clomiphene is anti-estrogenic on endometrium and interferes with implantation, so its live birth rate is very less. Is it okay? Any other query? Ethamsilate. Any other query? Ethamsilate is not an evidence-based treatment. Ethamsilate can be given, but it is not evidence-based treatment. Is it okay, Dr. Sumit? First line drug for menorrhagia is Trenexa. Beta, it is used as clomiphene. They both are SERM, selective estrogen receptor modulator. First line drug is Trenexa. The second line, if it does not get, is OCPs or progesterone. Is it okay? Any other query? Please feel free to ask. Can we close the session? All the important images related to these topics have been given in the Telegram group. Please see them. "16. Dr. Sheffy has asked 16. Sorry, I missed it, Dr. Sheffy. In a young female, we cannot go for. In young female, we cannot go for DNC. We cannot go for DNC. In a pubertal female, we cannot go for DNC unless and until life-threatening. Okay, DNC is reserved for the patients more than 35 years. Okay. Is it okay, Dr. Sheffy? What is the treatment of active bleeding in young female? Estrogen and progesterone. Any other query? Please feel free to ask. Queries solve a large problems. In the active bleeding, beta, if it is an active massive bleeding in a pubertal female, because we cannot do DNC, the treatment is estrogen and progesterone. Because we cannot do DNC. In a pubertal female, anything else, beta? Any other query? Can we close the session? Dr. Sheffy, most common cause of post-menopausal bleeding is beta CA cervix. Most common cause of post-menopausal bleeding, post-coital bleeding, both is CA cervix. Okay. The second most common cause of postmenopausal bleeding is endometrial atrophy. If CS cervix is not given, then it is endometrial atrophy. Is that okay? So I'm closing the session here. Thank you for coming and participating in this quiz. See you soon.